This is Duke University.
It's my honor to introduce our closing keynote for the conference, Pape Gaye. So a little bit of background on Pape Gaye. For nearly 4 decades, he has advocated for, built, and leveraged strong partnerships with governments, non-governmental organizations, and the private sector, to catalyze global health progress. He's done this by contributing to improving the performance of health workers and the systems in which they work. Pape started his career in international development as a trainee of Peace Corps volunteers in Senegal and Benin. And now, as the president and CEO of IntraHealth, he continues to pursue his lifelong commitment to the provision of healthcare by collaborating with public and private sector leaders, especially in low and middle income countries, to be able to encourage sustainable development in vulnerable communities. He is also recognized as a global expert and advocates for family planning as a high-impact solution to address health, population, and economic development challenges. As an expert in these areas, Pape Gaye writes and speaks extensively on these and other global health and development subjects. He holds an MBA from UCLA, and he currently serves on the board and in an advisory capacity at Johnson & Johnson Global Public Health Advisory Board, Partners in Population and Development, the Center for African Studies, the Triangle Global Health Consortium, and Duke University's Global Health Institute. Well, it's with great pleasure that I introduce Pape Gaye to the stage to give the closing address.
Thank you so much. Thank you so much, MF. And it gives me a great pleasure to be the keynote speaker for this event. Of course, it comes straight to my heart, being an African and being committed to advancing our continent the fastest we can. One of the reasons I'm so excited also is I do think that the solutions and being able to provide health access to the last mile lie with this community, with the communities of business-minded people and entrepreneur-minded people. So I was inspired by a panel I just attended on the education. Really would like to thank the panelists and the brilliant panelists and the conversation. And for me, it was a stage setting because I think it was Ameka Sai that said, this notion of taking every challenge that we have and turning it into innovation opportunity and eventually maybe into a market opportunity, or at least to address sustainable solutions, because that's when we talk about healthcare and the health workforce, which is the subject of my talk, it's all about that. It's all about seeing the health sector as a sector that's going to allow us not only to produce and deliver health, but to also produce and deliver wealth. It is extremely important as African in our new thinking that we refuse to just say that we're a victim of poverty, we're a victim of diseases, and some saviors is going to come and help us. It is important that the conversation goes around how can we invest in the people of Africa so that they can take charge. Because if they're not healthy, unfortunately, my friends, they're not going to be able to participate. They're not going to be able to start. So health is actually the beginning. This is why it is so important. This is why the subject of health, it's not just training health workers. It's not just seeing things in the length of the health worker. It's seeing things in the length of people who are in the business of delivering healthcare. Healthcare is just way too much of an important subject. It is high time that we stop thinking that the health sector is a drain to our economy. This is, unfortunately, the mentality that most of our leaders still have. You hear so often the health sector is the poorest negotiators. They don't know how to make the argument. They're always left behind. 3 countries in our continent were able to meet the pledge of the Abuja pledge of dedicating 15% of our budgets to health. Only 3 or 4 maybe. It's just pathetic. So we need to do that. The good thing, which is going to be again the subject of this talk today, is that we can now start to talk about health in economic terms, health in business terms. It is important that we don't forget that we still have so many people that need our help, so many people that needs to be lifted out of poverty, but it is an exciting subject, and thank you for staying late in the conference to participate in this conversation. So let me just take a few minutes to, this is our beliefs at IntraHealth. I mean, first of all, we just believe that everyone everywhere should have access to the healthcare they need to thrive. And I want to insist on that thriving. It's not just want to be healthy and get out of the hospital, get out of the clinic, but to thrive. Because if you don't have the desire to thrive, you're not going to go anyplace. So that is really, that's important to us. That's what we see. So our mission is to improve the performance of health workers and strengthen the systems in which they work. And I'll tell you why it is actually so important for all of us to mobilize to participate in the health sector. This is where we are. We are a medium-sized organization, about 550 employees around the world. We work in about 38 countries right now. Over the years, we've worked in 100 countries. We were a program of UNC. We spun off about 13 years ago, so we became an independent NGO 13 years ago. That's when we started actually growing, because as a program of UNC, I think it was fairly limited in terms of scope. These are some of the areas we work on. We are basically a health NGO, but our big specialty is the health workforce. Just to share, because I think it is important to think about the so what that you're doing. We do have an impact model that puts at the center this idea of thriving communities and societies. And really that's what Africa needs. I mean, when I think about our continent, it is just, we're plagued by this problem. And we need to just say, we want it, we're hungry for it, we want to thrive, we want to do it ourselves. So we want individuals and communities who are committed. It is happening, believe me or not. Whether we continue to do the advocacy or whatever, it is happening. So it is very, very important that we do that. We have these thriving communities. So we do want to, being poor does not mean having poor quality of care, does not mean having to take a substandard quality of care. You want the best care that you will wish anybody, regardless of how wealthy they are. So that is really the idea. In the blue, light blue, UNC blue type of thing there, you see we really have a comprehensive, and it is important that you think about these health workers as people that have needs that we need to meet, that have rights that we need to meet, etc. They are not just statistics. The problem is we tend to focus on the statistic. We tend to focus on the shortage. Africa only has 3% of the health workers in the world. It masks the real thing. These are real people, as we saw in the Ebola crisis. So glad when Time magazine finally put them on the face of the earth and named them Person of the Year. Because these are heroes. These are real heroes, but they are people with needs, with hearts, with faces. So it is important that we make sure that they are present, meaning that they are where they are needed the most, They are ready, meaning they have the proper preparation, proper training. They are connected. They're connected digitally, because if you're not connected digitally, you're not going anywhere. You know that. And that they are connected to their communities as well. And then they are safe. Unfortunately, not only do we have not enough health workers, but we have this weird situation that they are being killed left and right. People now are, you see there's conflict, and they attack hospitals and they attack health workers. And so we just need to rework to make sure that they are protected and so forth. And then in the green circle there, it is really about contributing. What is the role of these health workers in strengthening health systems? They are not disconnected. It's all one thing. It's building resilient and dynamic health system. As we saw with Ebola, as we see the whole talk about global health security, they're not going to thrive. They're not going to be contributors to society, and they're not going to be productive unless we have robust health systems that can support our communities and our populations. And then, of course, you need to take a look at human rights, at gender equality, at economic and environment, the changing health needs and population. You know, it is just changing. It's not the same. The nice thing that is happening in sub-Saharan Africa today is that with the economic growth that we are enjoying, because yes, we are the fastest growing economy in the world right now, very steady, and with that, we're also seeing a shift in the epidemiological profile of the continent. We are seeing a lot more non-communicable disease. We are seeing a lot more diabetes, a lot more hypertension, and it's no longer just this non-communicable disease, malaria, diarrheal diseases, HIV/AIDS, and so forth. So and we need, every system needs to take that into account. And we're all committed around the world to look at leadership and governance. I heard a lot of that in the education panel. It is so true. And you symbolizes all of that because you are the next leaders. You are the next generation of leaders. And governance is everything. And it is high time again that we combat the scourges of corruption, finger pointing to all of this. It's all doing it right. So it is extremely important that we pay attention to leadership and governance, policy, advocacy, community engagement, and so forth. At IntraHealth, the orange thing is just for us areas of focus in these last few years. As we were doing our strategic plan, we made commitment to highlighting really these three. And you will see why it's important, because in fact, that's the reason of my presence here, because we think having private sector approaches is something we have to do now anymore. It is no longer the old missionary model where people with lots of money come to the continent to save the poor people. There might be some of that still going, but we are in a new era. We are in a new era where you can talk about enlightened self-interest. We are a global community, and we all have an interest in having healthy population. You know, the West is looking for new markets. Africa is one of the next biggest markets. And it is important, so for the West to put money in ensuring health is not a gift. Whatever your political view, you might want to say, I'm not going to give money to corrupt government and all of that. Wrong narrative. The reality is we need Africa. We need Asia. We need all of these markets. But corporations won't go anywhere if they don't have solid markets that thrive, that grow, strong middle class, that can purchase these things. So it's an investment. And the sooner we can put that in our mind, the better off we will all be. So that's why we are saying we don't want to, as a nonprofit, we have a lot of values, and we attract employees who care about saving the world, making this world a better planet, etc. All of these things that we want to do. But let's be realistic. If we are going to create sustainable communities, we need market solutions. We need private sector solutions. That's why when I finished my MBA, I opted to stay in development, because it was my feeling that this is going to be very, very important, and it's going to become increasingly. So that's why we're doing that. Digital health. Digital health, for the first time, we can dream. We can dream of reaching the unreachable population. For the first time, we can help health workers not be so isolated in some remote communities, or we can make sure their salaries get there via M-Pesa. They don't have to wait 2 or 3 months anymore for this money to be sent on some wires and never arrive. We can multiply the number of health workers that we train by using digital tools. We can democratize learning. We can do telemedicine. We can belong to a community, a global community, where everybody talks to each other, regardless of where you sit. So Africa cannot be left behind the digital movement. We have to be part of it. As a matter of fact, not only are we part of it, in a lot of cases, we're first. Where do you think mobile money came from? Nairobi. M-Pesa. Those solutions were developed. People are calling it this horrible term of reverse innovation. I don't know what that means. It is innovation. Innovation comes where people have needs, and they put their creative minds, and they come up with a solution. Okay? But we're seeing that a lot, you know. The nice thing also about this, we have to make sure we don't want to continue this model of just continuing to develop tools and then shop them for a market or for solution. We need to develop with the users, with the users in mind. You know, we need to make sure that these tools that we are developing are developed to really create real problems. That's why we are focusing on this at IntraHealth a lot more. And we are focusing a lot on measurement and on analytics, because that's what everybody wants. I think sometimes it's overdone, but you have to do it, because donors want it. You want to know, you want to measure. They say that you can only, you know, you'll appreciate what you measure. And that's actually a very, very good thing. So we apply our technical expertise to help countries make life-saving, preventive, curative. Now, I just want to take a few minutes to talk about why it is important to also think primary health care. Because we run the risk of leaving a lot of people behind if we don't focus on primary health care. I put it here because we're not going to have universal access to health care if we don't pay more attention to primary health care. We're not going to meet the Sustainable Development Goal as we design them today unless we find a way to reach more people. Unfortunately, our leaders in our countries are not that focused on primary health care. They pay lip service to it. Where do you think our leaders go when they get sick? They take a plane, and then they fly to Europe to get cured, because they can afford it. Not our citizens who live in very remote areas. So we actually need to reverse things. Rather than talking about how many doctors we are short of and how many midwives we're short of, which is extremely important to do, I think we should prioritize community health workers. We should prioritize frontline health workers, because they'll get the job done much quicker, because they are so much closer to the population. That's why I like, when I speak, to make sure I remind all of us how important it is. And we can do it today. 40 years ago, many of you are not born yet, but when Alma Ata Declaration was put out, which is still the same, you can read the same word, it was lofty goals. We did not make a lot of progress. We made some progress, but we could do so much better. I think it's time to revisit primary health care and to say, okay, how can we do this? Because we have now things we did not have 40 years ago. We did not have a vibrant community of social entrepreneurs like you guys sitting in here. We did not have technology. We did not have the openness to do things with the private sector. These are all new things that we did not have some short 30 years ago. So I think we can dream and we can succeed in having vibrant primary healthcare system today, and that will only help our cause as creating business in health. Okay? And we have failed. We just have failed. So I think solutions are needed, and multiplicity of solutions. So revitalizing primary healthcare is key to achieving those. So let's begin to talk a little bit about the private sector, why this is important, why this is happening, and some examples. I mean, this is private sector approaches in the primary healthcare. So partnerships with diverse group of private sector actors, including global, national, health, non-health, faith-based, private health system, individuals. We just need to change our mindset. We used to see health and the health sector as being so kind of separate. We used to see the nonprofit sector as so separate from private. My friends, the lines have now very blurred. It has become very difficult to say where does the nonprofit stop and where does the for-profit begins. And we'll come back to that a little bit with shared value model and all of that. And there's still lots of work to be done, but I think we have to have this mind shift and then just say that business is everybody's, health is everybody's business. Policy analysis and development to foster public-private collaboration at country level is needed. I know we are talking a lot about it. I know it's now part of our lingo. I know there seems to be commitment to do that. But we seriously need to work on this. It's okay, as long as we just recognize that it's an important thing and we need to do well at it. We're learning. I mean, at IntraHealth, that's why we took it as a strategic direction for which we can better our organization, we can better prepare ourselves, because we don't know. We're still learning the rules of engagement about this. But it is needed. We need to continue the advocacy. We need to encourage country to say, yes, we believe in public-private, and this is how we are. And a lot of things that the public sector needs to do is relax a lot of the rules that they have, because we still have a lot of rules that do not favor creation of market solution. And we need to encourage this mixed market approach, because the train has left the station. We are in a world where now we have mixed markets. You no longer have health as just being the business of the Ministry of Health, okay? We now have a world where you have to say they're a mixed market. There's public markets, there are private markets, and you just let it grow. Because as we get a little richer, we have a little bit more money in our pocket, we should have more choices. So if we put ourselves in the shoe of the consumer of the future, of today moving on, their needs are going to be mixed. So to respond, we need to create this market, this mixed market. Hence the opportunities for you, most of you, who are looking to create business in the health arena. Some illustrative examples of some of the things that we've done in the past. We have in India a phone-based solution called MSAKI, which we had developed mostly to facilitate communication with frontline health workers, so that they have these frontline workers called the ASHA, which are the accredited social health workers. They mostly go into the communities, they identify problems, and then they help take those people into the clinics. And so our solution was designed to do that. But our solution in India now is being used in a for-profit kind of model. It is being handled by smaller groups who are looking into making this lucrative model. In Tanzania, we are working with Vodacom because a few years ago we acquired this little platform. It was a startup company in San Francisco that developed this platform called Switchboard. And Switchboard allows you to actually connect all of the health workers in a given countries so that you can have access to them at the touch of a button. You can send messages, you can think about this. Later on, you can attach money into it, and then you can use that. So anyway, we're pilot testing it in Tanzania. We're working with the phone company. In exchange of us delivering as many health workers to their system, because it brings them more clients, then they, in exchange, they create a closed user group, and the people can communicate among that for free. So anyway, everybody wins. Phone company wins because they get more clients, they get more money. The ministry wins because they can communicate much easily with their company, with their health workers. We have created with a bank, the Loan Education Board in Kenya, Health Education Board. We've created this loan fund called the Afya Elimu Fund, which as of today have helped graduate 9,000 people, health workers from remote areas who could not have access to loan. Because of this program, which is a very low income, very low interest, I think it's 4% as opposed to your traditional 12% in the market, they can get a loan and go to school and contribute to replenishing the health workforce. It's a market solution. You know, they repay and money is made by the bank, etc. I was talking to somebody in the early days of this Pratt initiative. We were actually worked with Duke Engineering. Our involvement was only at the initial phase for identifying the market in Rwanda at the time. And through the Clinton Global Initiative, where we had a fistula program, we created a public-private partnership. And as of today, we have Orange, the phone company. We have the Rotary Club. We have many corporations that joined the initiative. And the small investment of $500,000 that we had has yielded more than 12 times that today. And we are able to put more women suffering from fistula into this program by leveraging the private sector. So definitely it can be done. So at the macro level, I think it's this notion that health is an investment. It's not a drain into the economy. It's an investment. I think in this country, in the United States, according to that Lancet report, Global Health 2035, between 2010, I believe, and 2016, and at least during the decade during that period, I think 18% of economic growth in this country was directly attributable to the health sector. In a lot of sub-Saharan African countries, it's probably much, much more. So it is an investment. It's not just, it's going to pay off, because when you think about employment, when you think about the number of jobs that it can create, I think there's a slide coming up actually, a little bit more. And then the fact that you're also investing in women, because the health workforce in majority, everywhere in the world, is mostly feminized. It is just so. You are also empowering women and providing a lot of jobs to women. Okay. So yeah, by doing that, you're investing in healthy populations, you're investing in human development, and you are investing in social and economic growth. Okay. Now, I borrowed a few slides here from actually this brand new material. I don't know how many of you have seen this or are aware of this thing. Okay, so this is part of a whole new way that WHO is looking at investment in health. It is really there's been a high commission that was created that was headed by President Zuma and President Francois Hollande, and it is investment in health and economic growth, investment in human resources and economic growth. So some of these slides is drawn from that, investing in the health workforce. So very simple. The global economy is projected to create around 40 million of jobs between now and 2030. Okay? So some of those jobs will be in low-income countries, a lot of them low and middle income, as you can see, upper middle income. You'll see high income. What is sad, unfortunately, is that with those objectives in mind, today, the statistic is that we're short about 7.5 million health workers if we count doctors, nurses, and midwives. If you factor in the Sustainable Development Goal, that deficit actually is going up. It's going to go up, it's much closer to 10 million now, probably. By 2025, it'll be 12 million. And then with the new calculation, actually the ILO, International Labor Organization, has one that even sees a more severe one, which is, I think, going to take it up to 20 million. So we're going to be talking about 18 million shortage is the real term we're talking about. This is what the world is lacking. And Africa, unfortunately, suffers a lot from these global statistics. Because what this means is that a drain in the personnel that we are training. Because that shortage is global, including countries like the United States and England and so forth. They're in great need of these health workers. They cannot produce enough from here, so they have to import them. So between the pull and the push, the situation is just going to get worse. Unfortunately, most of the projected shortfall is going to be in low-income countries. So that's a challenge we have. But there is a case for investment. Because really, if you look at this pathway, if you look at health systems on one side and you look at economic growth, you see the connections. You know, the health sector will allow you full income growth and will allow you improved labor supply and productivity. You'll just have people who are not suffering from malaria and end up being so non-predictive because we lose billions of dollars every year to malaria because people are just sick and at home. So if we have healthy people, it's going to translate into much, much improved supply. Economic output, of course, because you'll have services, you'll have goods, you'll have capital assets. Social protection, so you'll have reduced inequalities. Anyway, it goes that way. So you see the connection is extremely strong. So there is also new evidence that talks about health being a multiplier of economic growth, as opposed to the old school, which was talking about being a drain in the economy. Health is a leading economic and labor sector. 67% of the health workforce are women. So this is it, compared to 41% of total employment. Okay? And a fourth of economic growth between 2001 in low and income countries was a quarter. Okay? And the return of investment is estimated to be, on every health worker you invest in, you'll get almost 10 times the return. So there are definitely some key messages to conclude. Health is a key economic sector, growing source of jobs, a driver of inclusive economic growth. Investment in health employment don't only result in a healthier population, they can drive economic growth, boost global security against outbreaks and other emergencies, and help countries achieve sustainable development. We are calling for a fundamental transformation in the way we look at the health workforce. It is not just about increasing the pipeline. That's a wrong approach, because we're not going to do it that quickly. You cannot see these huge gaps that Africa only have so many doctors. For the foreseeable future, it's going to continue to be that way. So we have to be creative. We have to find ways to live with this problem. I'm not saying we should abandon it. We should continue to try to improve it. But you need a fundamental shift in the way we look at it. Stop thinking that it's just about numbers. It's about productivity. You know, today in the public sector in sub-Saharan Africa, I'm sorry to say, there's been studies that show that productivity can be as low as 30%. Because in the public sector, you don't see people come in, they show up to be seen, and then they're off to go do some other work or go to do their private clinic or something. But it's just not working. So we need a labor market policy to ensure that investment. We need a labor market because we're not going to be able to retain people in the countries. People are going to go where they can make more money. The remittances that they send are much more important than what a lot of people can make if they stay in their countries. It's a very complex problem. So you have to just see the world and say, this is a labor market. It's a global labor market. How do we play in that? Very quickly, because I know we want to have a little bit of time for conversation, stronger international cooperation is definitely needed to address the workforce issues. It is a difficult problem because all of these health systems things are very difficult. Everybody thinks it's important. Everybody knows it's important. Nobody really want to participate. To me, the analogy is just the private sector. You know, if Google want to do business in Africa, they need to invest in improving the infrastructure. You know, but everybody wants to avoid that. Everybody wants to wait for somebody else to build the infrastructure so you can come in and ride on it. Doesn't work that way. Everybody needs to pay a price for it. I hope that we can mobilize as a community to find ways to get these companies, to get the donors, to actually fund monies that should go to health system strengthening. Nobody wants to touch it because it is so complex and it is so hard to count. It's much easier to count the number of people that you have trained or the number of HIV people that you've put on HIV. Those are much, much easier. PEPFAR has this mechanism where they count very well. But we need to find a way to do that for health system strengthening as well. So, and it's a global problem. It is not fair for the international community to just say, well, the systems are weak, you fix it, or just think that the ministry alone can do it. It really needs collaboration. So those were the messages. We'll stop here. There was a lot of information, a lot of talking at you. Let us stop here. I think we still have time for a few questions, I believe, right? Okay, great. Yes. Yes.
So actually my question is, at the beginning of your introduction, you said that our self-proclaimed leaders go to the US or to Europe to get medical care, but we also have middle class going to the migrate. So I want to know actually what is the key difference between the sub-Saharan Africa and the Maghreb, knowing that in these countries you also have a very good healthcare system and you have dictatorships as well. So what is the key difference between the two regions of Africa? And the second very short question is, now with the rise of technology, how do you do to deal with counterfeit drugs in Africa?
Yeah. For your second question, I think there was a session this morning. Proxil was here. There was a brother, I believe, who has a company that is actually looking at use of technology for detecting counterfeit drug. I think that there's actually a very strong movement to find how we can do that, because we are at a stage where we should be able to do a much better job. Either find a way, a little gadget, or the way we label the drugs. But there's a very strong movement going on that. Now, on your first question, so if I understand correctly, it's the movement that happens between people going like to Morocco or Tunisia, or people that are a little richer. You know, it's somebody was mentioning Maslow's hierarchy of needs. I think people, when you're at the bottom of the pyramid and you have so much need, you go what you can afford. The next best thing for a Senegalese middle-class member that has some serious issue, probably cheapest would be to go. The cheapest place from Senegal would be Morocco or Tunisia. It's just it's a cost. It's an economic thing. It's even if those countries still have a lot, they do a little better in the other countries. Now, we are doing a lot of work in Kenya, and I'm very active with the Kenya Healthcare Federation and the private sector operators in Kenya and all of that. Most of the conferences I've attended in the last couple of years, the subject of how to make Kenya a destination for neighboring countries for medical tourism is on the agenda, because they want to do that. Senegal is doing the same thing, because it is a little better off than a lot of those countries. Can it become a hub for the other sub-Saharan countries? So it's just, I think over time, that is probably a good evolution of things, but I think it's just depending on economic needs and how easy it is, border crossing, visa, whether you are in ECOWAS or outside of ECOWAS. I think those are the factors that mitigate that.
Thank you for the presentation today. We appreciate the time you do. My question to you is in regards to healthcare workers and balancing, providing them with, a financial proposition that's worth what the service that they provide, while at the same time keeping the costs of care low enough to make it accessible to the population. And I'll tell a very short story in regards to that. My family owns a clinic in Cameroon. And about 16 years ago, my mother, just out of desperation, decided to get into a shared ownership model with the doctor that she brought into our clinic. So we went from 100% ownership to having the doctor be the majority shareholder. While that was, and all of us were mad at her for making that choice. But fast forward now, the clinic has gone from having him just being a pediatrician to him having grown the clinic to bring in other specialists, and now it provides gynecology, dentistry, and is getting to surgery. And it's gone from a couple of nurses to 10 nurses.
Right.
So it has worked. So is that sustainable? And what do you think about that kind of approach, making the healthcare workers shareholders of?
Absolutely.
Yeah.
Absolutely. I think these are where the opportunities are, because, it is clear that the old approach has failed when it comes to sustainability, because in the majority of our countries, first problem, we had left health to the donors. Basically, we have washed our hands. We just said, the NGOs and the donors will take care of it. The faith-based organization will take care of it, and so forth. I think if we're going to have market solutions now, these are the kind of things we should start thinking about. Because, ownership is going to be extremely important. If people feel like they're shareholders, then they're more likely to redouble their investment and their commitment and their active engagement in this. This is where the beauty is. I'm a strong believer, for example, that we need to grow private networks of community health workers. There is an organization in this country, I think it's Living Good. That's a model that they have. They have this kind of a community health workers. You organize them, you encourage them to get some income generating activities. You know, they are part of the enterprise. They're part of the enterprise, and they are most likely to find something that's more affordable and so forth. The other part of your question is also an important question, is that if you're going to reach the last mile, you're talking about people, including people who are still in extreme poverty. We're making progress eliminating that so that we'll have people, very, very few people living under $1.50. But you still have a lot of people who cannot afford health care, who will, and remember, we need to provide social protection. One of the things we want to do is reduce the number of catastrophe due to health care, out-of-pocket health care. So my own theory is that the health care is going to need these subsidies and this support for a little while longer. We need to be accompanied a little bit. Because, you know, you cannot, in most market, you cannot just go, if you wanted to just stay private, your market will be limited. You can make money because there is high income and there's growing middle income in a lot of great cities where people can pay, but your market will be limited. So I do think that a strategy that allows you to price discriminate or segment your market so that you can differentiate the price according to people's capacity to pay, I think would be good. There are actually groups like the Abraj Group, which is a Dubai-based group that has raised $1 billion fund, and their objective is to try to create these networks. They're buying clinics and so forth, and they're trying to create this model. But that's part of their strategy is to be able to reach the last mile. And if you're going to reach the last mile, you have to address the issue of access to cost. Yes, Philip.
Yeah, thank you very much for your presentation. And I think, I'm glad, in fact, to see that we are revisiting the primary health care concept, the Almatan Declaration. Mm-hmm. Because I happen to have been around the time and practicing when the principles of the Almatan Declaration were there. And a lot was achieved. And then from that time, there was a lot of change of terminologies, and people got lost in that. We lost a lot of resources, we lost a lot of time, because we moved from primary health care. Yeah. And then before we recorded, we went to Safe Motherhood, and then from there we went to Making Pregnant Safer. Yeah. So we came with a lot of terminologies, and all those were project-driven. And because of that, we lost a lot of resources, because every time you change from, let's say, primary health care to Safe Motherhood, at country level, they used to start by creating awareness, orientation programs for the new program. The resources were used at that level, right. Writing very good documents, glossy documents, most of them which never left, in the printing area, because by the time those documents were ready, there was no money to take it down to the grassroots level. So there was kind of a yo-yo phenomena. Primary health care comes down, and before it gets to the ground, Safe Motherhood comes, we go up again. Yeah. And then like that, and it continued. And I think it's good that we are going back to the primary health care approach. And I'm glad that Intra has also come in with the private sector, because I think that is what is going to create sustainable kind of programs in healthcare. The question of community health, community-based workers, was a very strong program. Most of the countries which achieved a lot, they had strong community health workers. But along the way, again, that was kind of shut down, and there were a lot of, very little resources going to that. I don't know whether that is still the trend, because I don't think we can avoid having community-based workers. So I don't know, I think you'll enlighten us on what is happening at that area.
Yeah, I think we are making progress, Philip. I think there is certainly a lot of interest. I mean, there are countries, Rwanda, Ethiopia, that have really shown commitment to these community health workers by really doing some very innovative things. Ethiopia brought in 40,000 new health extension workers. It's a new cadres of workers. The president of Rwanda made personal commitment to support these community health workers by providing them with the tools and cell phones and so forth. But the problem is the problem of sustainability. So you have a lot of models, you have NGOs coming, trying things. Everybody, if you have a 2-year program or a 3-year project, you can pay people, but what happens after you leave? So I think the solution would be, in my opinion, for governments to enact policies that are favorable, that will create an enabling environment for the actors to do the work. I do not believe in governments managing and running those programs of community health, even the ones that are currently working fairly well, and whether Rwanda, Ethiopia. I would be happier if I saw counterpart private sector or civil society run. Because the beauty of community health programs, they don't have to be monolithic, they don't have to be one same program. The beauty is, because it's so dependent on the context, and you really need to let the context take care of itself. What type of community is much more, should they recruit? Should they focus on having pairs, men and women? Should they go primarily women? All of those things you should leave to the communities, to the decentralized structure. But create a policy that's going to favor this. Public sectors, I think we have to bite the bullet and say, you're not going to have volunteers for their life, for the rest of their lives. If you want them to be productive, you need to do a little bit more. You need to create an environment where they can grow. You need to create, just for all of us, you need to create a career ladder. Why not having a step ladder approach where, they can do some tasks, go to school, and after they certain level, they can move up. You need to pay attention to it. You need to stop thinking about them as not being part of the system. That's been the problem. In every sub-Saharan Africa that you go to, you look at the pyramid of the health system. You'll have hospital, you have health centers, you have health huts, and then that's it. Community health workers don't belong anyplace. They are not part of the system. We don't count them. We don't know how many there are. We don't know where they. So we need to do those basic things. At the federal level, we can have the policies, we can have a system to count them, and then you need to liberalize it so that people can create them. But they're extremely important. I think they are going to be the answer to the shortage of healthcare workers. Yes, there's a question way up there.
What do you think is the path to establishing standards and regulations to safeguard patients and ensure that they get quality?
I think increasing and amplifying the voice of the patients and the communities, because they're absent from the dialogue. We try to do, what you have in my region of the world, Francophone West Africa, highly medicalized system. The French system in general was just very, very hierarchical and then, the doctor becomes everything. They make all the decisions, they call the shots, the system just remains too hierarchical and everything is top down. And we think about the patient as a last. So the patient or the communities or community representative or community leaders need to be at the table, need to be given an opportunity to increase their voice. And you need some culture shift, because a lot of people still don't believe that they have the right to ask for quality. You see, they don't believe they have it. They're happy if they're seen by a medical worker or by a health professional. They are happy. You know, we need to tell them that there's much, much more. Not, they should be happy, yes, but they have a lot more. It's their right. So we need a lot more players in that kind of an advocacy, helping people know that this is their right, this is something they need to ask. And we need to have people keeping our governments and our leaders accountable. It is time that Ministries of Health does what it's supposed to do, which is ensuring quality of health to its population. And we just need to emphasize, we need to have checks and balances. Yes?
You may probably forgive my ignorance because I don't have much knowledge of health. But then again, everywhere I go, there are a lot of efforts that are being put in healthcare. Clever governments are planning for the tasks ahead. For example, Africa, we talked about over 60% of our population being young people. Young in the sense that they attract lesser health situations than they have. But when you look at the future, you're looking at, as they grow old, the health requirements increase. Now, I've not seen the governments addressing those issues in that sequence of development. The other question is, the other thing is, as the health workers are doing everything to keep the population healthy, I am told, and I don't know how official this is, that companies like drug companies are just thinking about business, coming up with drugs that just manage circumstances and not clear, not resolve.
Yeah.
Now, you people in health, doctors, nurses, and everybody else, why would you let governments, why would you let you work so hard to resolve issues? The drug companies, which are supposed to be partners, are just bringing up drugs that are managing circumstances, and you're letting them do and continue to make money. Why have we let the monopoly of drug manufacturing be to just a few people? This happened in the 80s when the companies were buying each other.
That's right. Well, we all have our role to it, including you. You should stop saying, I don't know anything about health, because you do. Because you are, because we all do. I mean, that's the message here. I mean, this is the one sector. This is why the health sector is so important. For the longest time, we have put these barriers, and the enemy is us. So if everyone has a role to play. If you just raise your voice like you just did, you've played a huge role. And that's what we need to do. We need to get to that level of being conscious ourselves that this is something I had thought I had left to somebody to take care. But no, this is part of human development. Yes, as you say, a life cycle approach. You're saying, why aren't our countries adopting a life, because that's what it is. It's a life cycle approach, which starts with maternity and then go up to, to aging. And so that's why you just have all of these issues. So I think it's just this mind shift. I think it's the concept of mind shift. It's the concept of lowering the burden. Because if you only see the Ministry of Health as the major player in health, it's impossible. There's no way they can do this. It is just not possible. You need all the players. You need the faith base, you need communities, you need patients themselves. This is one area where we can say that. We can say, I have to take care of my health. Prevention is where we all need to get, right? Because that is really what we need to do. And that you start teaching in school. You start teaching kids to take care of themselves, take care of health. So it comes down to that. It comes down to the discipline, to the new discipline Africa needs to have to tackle all sorts of problems. I ran out of time with the education debate. The question that I had at my tongue was, can the education sector help us really in training the next generation of leaders to have people who have this integrated mind? because the SDG is calling for a sustainable development goal that are integrated. They're calling for us to think about not just health, but education, food security, environment, et cetera, et cetera. And that's what we need to do. It's difficult, but we need to have our focus, but then have our mind this way. You know? So to me, that's why you need more voices. That's why you need civil society. And civil society, unfortunately, the door is closing rather than opening in many countries. Because it's just, that's the only way it's going to happen. It has to happen locally. It has to happen from the bottom. It has to happen from people. People have to raise their hand and ask for it to happen. I know you guys are.
I know this is a very exciting discussion, and thank Pape Gaye for all of this.